provided by our colleague from Pfizer, but it tells us as long as we are delayed, so there is some kind of a losing. So you lose as you delay. So as early as, because it's kind of a more logic. If you see that there are serotypes that are circulating already, and we know that they do some kind of a hazard to our patients and colleagues, so it's really needed to start. Delaying is not good for anybody to look for it. And again, this is the saving for starting or doing the replacement for people based on data from the United States, $8 billion US dollar in direct cost, and also 300 millions in indirect cost, for example. And again, as I mentioned, we don't look for the direct and indirect, and also even we don't look for the long-term impact of such a disease. So a patient come with meningitis, for example, he may come with a disability. We don't look for such kind of stuff. We don't look for patients coming with pneumonia and currently admitted to the hospital with pneumonia. We don't count for even such kind of, or a patient comes with otitis media and may come with losing his hearing, and also we don't count for that. So many kinds of indirect costs that we don't look for it. And come to the recommendation here, 20 adding a value for more serotypes, and compared to the polysaccharide, it add another value for more effectiveness. So that's why even people who came with 13 and 23, they received both vaccines, they still need 20, because 20 has, again, more serotypes. So you need this more serotypes to be included. So 13, 20, and then you just really a need for 20. So if the patient came without anything, he need 20 for sure, start with it. And even if he starts 15 and then 23, again he need 20 because of more serotype. If he received only the 23, he need the 20, again, because of the effectiveness, because it's a conjugate vaccine. So this is the way that came with lots of dilemma that we got. And when it came to pediatrics, so the doses are kind of 3+1, so 2, 4, 6, and 1 year. And why this kind of a schedule there? Because of the data that showed us, again, the response, the immune response, the phagocytic activity that been there, and the maintained antibody. Having a duration after the last dose also gave us a good kind of a protection. We're almost done. And then also 3 doses if the child 7 to 11 years, and the booster dose if above 2 years of age, then 1 dose is required if not received the previous. And again, this is the same kind. Can we switch? Can we go with the booster dose with 20? Yes, definitely, because again, there is an additional, and it's the same vaccine. It's kind of an additional things on the same level that been included. And again, this is the same thing, that 20 and even 23, he still need the 20, and again, the polysaccharide doses, and no need to repeat. Polysaccharide need a repeat dose because of we lost the immunogenicity or immunogenicity with the polysaccharide without a conjugate vaccine or protein that been included. So losing this kind of a memory is an issue to be there. This data from Qatar, from our colleagues in Qatar, and Qatar was have a 3 dose, 3+0, so only 4, 6, I don't remember their schedule, but anyhow, 2, 4, and 6, and no booster, and they switched now to 3+1, 2, 4, 6, and 1 year. This is similar to what we have in Saudi Arabia, and also being recommended in the United States. And this is for how to administer the vaccine in general, 2 to 8 as a temperature use. And again, we train ourselves and our colleagues because this is an integral part for the whole effectiveness of the vaccine. If the vaccine is not well stored, not well administered, it will affect the effectiveness. So always we need to be familiar with such information that been also included. So it looks like there is some adding value with additional serotypes that been at the moment to look for what's the new serotype that added a value. And again, at the same time, we need to know our kind of epidemiology for sure. Because without kind of a good surveillance information and data, we don't tackle. Maybe we don't go with the same scenario that being there, or give us a more confidence that we are really in the same direction, right direction. But as long as we don't have a surveillance data, so a benefit of adding more serotypes, I think this is a very good public health impact at the end. So with this, I would like to thank you for your attention.
Professor, thank you very much, as usual. I would address the point that mentioned by the professor, the importance of availability of the surveillance system, not just for the pneumococcal, for the older communicable disease. Definitely that will help the policymaker to have their own plan for the vaccination program. So we'll open the floor, please, for colleagues if they have any questions.
Thank you, Dr. Majid. Thank you, Dr. Faisal, for your excellent presentation. In 2005, Dr. Mazroua, he has his first study, and then in 2014, Dr. Atif Shibli has his second study. In a country like Saudi Arabia, we don't have many studies. It's unfortunate. I was talking to Dr. Atif Shibli probably 2 months ago in Al Faisal University, and I told him that we need to do a study to look into the serotypes. And he said, I'm willing to do that. He has a facility, and we have microbiology master students. They can really work on that, but they need support because in our institution, they cannot really. They need support, and they need incentives for to do that. So this is where that's only 2 months ago. So that's something that's really needed. I know that there are experience, just like Dr. Thaqabi mentioned that 4 now is circulating, and probably 12 or 8 it's probably circulating, and we don't know. And there are data, but it's not really published, and we don't know about it. Okay, we probably know about it when we gather, just like our meeting today. So my question is, why we don't have any studies, and manufacturers are not really helping with that. So the question is for everyone, even for the manufacturer.
I'm going to give the answer to Majid. He answered this.
There are 2 things. First of all, very important question. This is very important question. Regardless of the vaccine, we're looking now, it's a public health kind of surveillance. And we need to know what's going on because things are changing every now and then. The replacement phenomena is there, and is there with different diseases, not only pneumococcal, but also meningitis. But generally speaking, there are 2 things. First, national surveillance, which is not research-based. We have like clean criteria, and it needs to be well established. And where the decision also needs to be there. Pharmaceutical companies, they can help at that level. We are not talking about research, but also at the national level. And I'm sure our colleague now, currently in the Public Health Authority, they start doing that. They start collecting samples from pneumococcal. They just last week they asked me for some samples, so I shared with them. In National Guard, we sponsored with the study. We collected a good number of isolates, and hopefully soon we will have a result. That is a research. It's not no. It's prospective. Yes, prospective. So we collected almost 120 isolates. It's multi-center across the kingdom, and mashallah in King Faisal, King Saud, National Guard hospitals. We have a good number of hospitals that represent the kingdom. The most important thing, you can see that the role of research centers and hand by hand, but with the pharmaceutical company, to have something meaningful, not only for the vaccine, but also for the safety and easy to take a decision, and also understanding what's going on. And the repetition of both of us, not only the Saudi Arabia or our own companies, but we are building partnerships. Partnerships need to be respected and mutually. I'm not going to do بالكلام يعني أنا ما قاعد أقول بالكلام بس هو it need to be mutually truly represented in that way. It's not only consuming, but also we are partnership and mutually have benefits from each other. Thank you very much.
Thank you so much for highlighting this important point. Questions for colleagues?
Thank you, Dr. Faisal, for highly informative lectures. You have mentioned PCV 20 effective mainly against type of pneumonia, clinical pneumonia caused by streptococcus pneumonia. But according to our background, there are different types of pneumonia caused by Moraxella, Cataralis, Rufus influenza is capsulated also, or Mycoplasma as Laxil wall, and other strains. My questions: what is the nature of vaccines? What is the formulation as formulated from polysaccharide strains? even from Streptococcus pneumonia only or other strains to be effective globally according to strains as endemic. Second point, you have mentioned child has to administer another booster dose. What is the gap between the first dose and the booster dose to increase the immunogenicity or to increase the immune system?